Thank you for having me here today. So we ended off the last session with a call for good surveillance, and that really warms my heart for a couple of reasons. One of them is that I have one employer and one financial interest, and that is also aligned with my passion, which is working in public health surveillance. So I have more slides than time, so I'm just going to leap in, and we're going to have a look at a geographic analysis of first and fourth dose DTaP IPV HIB. So we're going to be looking at 2012 coverage rates across the province, but the thing that we're adding to this is we're going to be accounting for risk factors. So we've seen the maps before of coverage across the province in a number of jurisdictions. If you want to see some beautiful maps, Google Interactive Health Data Application. Have a look at first to fourth dose DTaP rates across time, across the province. It's a beautiful visualization that gives you the rates today. However, the other thing that we're going to be interested in, and we've talked about it in a number of sessions, and we're going to drill down in a number of the upcoming talks, is the risk factors, what influences immunization rates. So we're going to be looking at immunization rates. We're getting these from AMARI, our provincial immunization repository. So it collects immunization and adverse reaction information. It's got complete data for the entire province since 2006. We've got some projects underway to actually try to go back and collect all of the electronically available immunization history in the province. It's, for most of the province, a near real-time system. So we're getting submissions for 2/3 of the province on a weekly basis, and they're about a 1-week lag. So we're getting very current information from the system. We're going to break the province down into 132 local planning areas. So these are used by Alberta Health and Alberta Health Services when they're planning service delivery. So very fine geographies, fairly homogeneous in nature. So in terms of the risk factors, we're going to be looking at 3 broad domains. So an access to service measure, a measure of, I'll call it household chaos, and an attitudes measure. What I'm calling attitudes here is a summary measure of a large number of components. So both the risk-benefit trade-off that's being perceived, as well as philosophic or religious objections. So that's all rolled into what I'm going to call attitudes. The interesting thing here, the thing to keep in mind, is that all of these are going to be measured as an aggregate, something at just the geography level. So I don't need to go and survey 40,000 parents every year to get this information. We're collecting it from other sources. So just very quickly, I'm not going to spend a lot of time on why these were chosen, but I'll give you an idea. So for the access measure, we're looking at, do you have a regular family doctor? For the household chaos measures, we're looking at proportion of families that move, proportion with 3 or more kids. Although the 3 or more kids, although benefited from the literature as a choice, I've got 2, and that was lots of chaos. And when I had 1, that was good chaos too. However, yeah, I guess 0 doesn't really come into childhood immunization too much. So, okay, in terms of attitudes, we're looking at a summary measure of attitudes, which is the adult influenza immunization rate in a region. And we're also able to identify some local areas that have had previous vaccine preventable outbreaks. So just so you have an idea of where this can come from, the family doctor and adult immunization rates we're taking from CCHS, the Canadian Community Health Survey. The moving and number of kids we're taking from census data, and the previous outbreaks we're taking from our communicable disease reporting system data. So all of the provinces, all of the territories have access to information like this. There's nothing in here that is, inaccessible. Okay, and this is generally where I play. I get to tell you all about the fancy regression and cool stuff I did. There you go. There's the one sentence on that. I want to talk about what we're going to be mapping, though. So if you went and had a look on the IHDA, on our interactive health data application, you would see the actual immunization rates in each of the local areas. What we're going to be doing today is, instead of actually mapping the rates, because we're going to have to adjust for some of those other risk factors, we're just going to map how far you are from, in essence, the provincial average. Okay? So how much better are you doing or worse are you doing as a region? Okay, so first, just a quick look at what mattered. So on the left-hand side, the household chaos and the attitudes mattered for the first dose of DTaP. On the right-hand side, you can see both the access, the chaos, and the attitudes all matter for the fourth dose. Okay? So the factors that are influencing uptake of the first dose vary by the time you make it to the fourth dose. Okay, and we're seeing this just in aggregate data when we're looking at small regions across the province. This I put in just for the fun of it. What you're seeing along the bottom is, from left to right, the percentage of families with 3 or more kids, and that black line is what happens to your first dose coverage rate as the fraction in a small geography with 3 or more kids increases. So it's got a large effect. The areas where maybe 10% of families have 3 or more kids, you're up around the 94, 95% mark. By the time you make it to 30% of the families in that area have 3 or more kids, you're down into the 80s. So it's something to watch. Okay, it's about mapping, so time for some maps. So these are, how far are you from the provincial average of 92% for first dose DTaP in 2012? My apologies for the little white areas. I'm not sure why PowerPoint ate those regions, but it did. You got me on that one. I'm good with some things, but that part is not me. However, have a look at this for a second. Think to yourself, have a look at it, identify for yourself where you see the chunks of red. Okay? Because I want you to sort of keep that in your mind and have a look at what happens after you adjust for some known factors. So we know that there's a household chaos effect. We know that there's an access effect, not much for first dose. Okay? We know that there's an effect of attitudes. This is what happens to your map, to your understanding of the rates when you take that into account. And this is important because, to go back a slide for a second, if you were to just look at this, think to yourself, what would you do? From a public health perspective, where would you go? Where would you target resources in the province? Now, if I then said, you know, there are some things that maybe we can't change. Maybe these are non-modifiable risk factors. If we account for those and take them out of the equation, does this change where you would go? That's the power of this. Going to do the same thing for fourth dose. We've got 73% coverage in the province. Have a look at the areas that are red, a little bit below that. The areas that are dark green, somewhat above that. Pay particular attention to the southern tip of the province for a minute. Watch what happens. Watch what happens after you account for a lot of these factors. Okay, all of a sudden, they're doing just as well in terms of program delivery as the rest of the province. So it's something to keep in mind. Okay. So, something you've seen before is the drop between first and fourth dose, DTaP. The interesting thing here to me is that the factors influencing uptake change over time. I think that's important. I think it's very important to see the effect of that, and the process of mapping, being able to visualize it, gives you a very immediate effect of that. You can have all the underlying analysis you want, but if you can't communicate the information clearly and succinctly, it's not going to help. So what does this mean in terms of future surveillance? It allows us to have a look at and control for modifiable and non-modifiable risk factors and be able to take those into account when we're looking at program planning. The other thing that we can do with this was all done with aggregate data. So it gives us a way to analyze information without having to absolutely go and collect everything all of the time. The reason that this works, you'll see in some of the next presentations, is that we have undertaken to collect the individual level data some of the time so that we know that this works. And that's it. Thank you.